Hi, I'm Jacques Abramowitz. I'm the co-director of the Fetal and Neonatal Medicine Center and professor in the Department of Obstetrics and Gynecology at Rush University Medical Center in Chicago. And today I'm going to speak about a topic that is very important for anyone who does obstetrical ultrasound, bioeffects and safety of ultrasound. Obstetrical ultrasound. Is all this safe for the fetus? Now, when one speaks about bioeffects and safety of ultrasound, there are two issues to consider. One is risk, the other one is bioeffects of ultrasound. And they're connected, of course. Now, risk means the chance or the possibility that something bad will happen. There are three important characteristics when we speak about risk: the probability that it will occur, the nature of the risk, and the magnitude of the harm. But unfortunately, there's a complicating factor, and that's personal views. Now, all these people may have a lot of fun and think that they're doing something great. I may think they're crazy. That's the personal aspect of risk. Now, when we look at risk, the evaluation of a procedure or an action can be done in one of two ways. We can look at risk-benefit ratio. That means how much harm is acceptable to obtain the desired result. But we also can look at it with the precautionary principle. How much harm can be avoided by not performing the action or by performing it in a different way? The precautionary principle says that if a certain action, in this case ultrasound, may cause severe damage to the public, in the absence of a consensus that there would not be harm, the burden of proof falls on those who advocate taking the action. In other words, those who say do the ultrasound have to prove that it is safe based on the precautionary principle. Now, this principle started in 1842 in England. There was a bad epidemic of cholera, and John Snow, who was a physician, said, well, we have to close one of the central fountains of London to prevent the epidemics from spreading. People thought he was crazy, but in fact he did that and the epidemic stopped. This was the first application of what was to become the precautionary principle that was used later in Germany, particularly in the environmental laws, to try and prevent some actions from the government that could harm the environment. Better safe than sorry is exactly the application of this principle. Primum non nocere, first do no harm, is another application. And of course, ALARA, the principle that we use in ultrasound and radiology, is another application of that principle. Now, David Toms, many years ago, stated that when one anticipates a specific benefit from ultrasound examination that cannot be obtained by safer means, he, today we would say he or she, should do it. On the other hand, when one does not anticipate a specific benefit from ultrasound examination, he should not do it. So, before we start, there's a question that is very important to ask. What is TI and MI? Well, why do we speak about bioeffects and safety of ultrasound? Sometimes we see this type of headlines in the papers. Could ultrasound scans cause harm to unborn babies? Or this type, and this was translated to me by Professor Marcel, ultrasound can harm your baby. And you see at the bottom of the page, the risk can be 30%. So what is the rate of exposure to ultrasound? Well, in 1984, there was an estimation that this was 1 out of every 2 children born in the USA. Today, 80%, 90% of 4 million infants born in the USA are exposed to ultrasound at least. And in some European, Asian, South American countries, it is close to 100%, with some countries allowing for multiple ultrasounds reimbursed by companies or by third-party payers. So, should the practitioner worry? Should the mom and dad worry? Should the fetus worry? Why do we even speak about this? Yes, really, why even speak about bioeffects and safety of ultrasound? We all know that ultrasound is safe. Ultrasound is not thalidomide. Many years ago, there was a medication called thalidomide that was used in pregnancy to decrease anxiety in the patients, and it worked very well for that goal, except babies were born without arms and without legs. So ultrasound is certainly not thalidomide. Ultrasound is not X-rays. It's certainly not atomic energy. Show me the dead babies from ultrasound. Well, ultrasound is a form of energy. It's a waveform with positive and negative pressures, and this energy can be transformed into thermal energy, that's an indirect effect on tissues, or it can have a direct effect, and that's mechanical energy. Positive pressure causes movements in tissues, negative pressure can induce cavitation. So ultrasound pulses, when they go through tissue, can cause radiation stress, acoustic streaming, nerve-ending stimulation, cavitation, and possibly release of free radicals. Cavitation is one of two things. Non-inertial cavitation is when bubbles that are in tissues do not collapse, but have a back and forth motion, and that motion can cause streaming, radiation forces, or heat production. The second type is inertial cavitation, where the bubbles in tissue grow and collapse under the influence of those waves, and when they collapse, there's a very, very high elevation of the temperature for a very brief moment of time. So ultrasound going through living tissues causes effects. These are called bioeffects. But there are no epidemiological studies demonstrating harmful bioeffects in humans. Yes, but all epidemiological studies are about exposure before 1992. Why is 1992 so important? Because in 1992, the maximal output for fetal applications was allowed to be increased by a factor of 8. So before 1992, the maximal acoustic output for fetal application was 94 milliwatt per centimeter square, was allowed to be increased to 720 milliwatt per centimeter square, which was the upper limit for general ultrasound. At that time, the FDA, under the pressure of AIUM, public representative, manufacturers, decided that they would increase the allowed output, and they created the Output Display Standard, or ODS. This stated that manufacturers may indeed increase the maximal output, as we said, up to 720 milliwatt per centimeter square, on the condition that two indices appeared on screen. One was the thermal index, or TI, expressing the potential for thermal effects, and the other one was the mechanical index, or MI, expressing the potential for non-thermal, also called mechanical effects. But, in addition, a particular effort was to be made to educate the end users about bioeffect, safety, and TI and MI, and we'll see a little later if this was successful. So the thermal index is a unitless estimate of the possible tissue temperature rise in degrees centigrade. Again, possible temperature rise. It is a ratio of the total acoustic power divided by the acoustic power needed to raise the temperature by 1 degree centigrade. Now, it predicts the potential for temperature increase. It is not a real temperature measurement. And, important, no time information is given with this index. And there are 3 thermal indices. TIS for soft tissues, used primarily in the first trimester. TIB for bones, used in the second and third trimester. Both these indices are the most used in obstetrics. And TIC for cranium when we do ultrasound through the skull, as we do in adults or in fetuses. And the reason being that bone is the most absorbing tissue for acoustic energy, therefore the highest possible temperature is in the vicinity of cranium. The mechanical index expresses the potential to induce cavitation. So of course, bubbles must be present. I said earlier that cavitation needs bubbles to occur. Well, there are no bubbles in the fetal lungs or the bowels. Therefore, the risk due to this effect, the mechanical risk appears to be low. So manufacturers must display the TI and the MI on screen. Where is it? Well, it's somewhere on the screen, and every machine is different. In this case, in the upper right corner, can be in other places. But what do end users know about these indices? Well, a few years back, we published an article where we asked people, end users, what they knew about safety. And we asked people who perform more than 5 OB ultrasound a day. So we didn't want people who did not perform a lot of ultrasound. And the knowledge was quite low. In fact, we compared this with a publication a few years before that, looking at end users in Sweden. Carol Marshall published this, and we both found that about 25% of end users knew what TI and MI stand for. So 75% did not know. About 2/3 did not know that these indices appear on screen during the examination. Why is this so important? It's important because heat is teratological. It can cause fetal damage. This has been shown in animal experiments. This has been shown where maternal fever in early pregnancy can cause anomalies, as well as external factors such as sauna or hot bath. So heat has been shown to cause defect. This is not heat generated by ultrasound, as can be seen. How hot can it get? Well, here is an example of an ultrasound, a commercially available machine, and you can see that the TIB in the corner is 5.7. So in theory, the temperature could rise by 5.7 degrees centigrade. Although again, this is an estimate, it could be more, it could be less. What are the recommended maximum exposure times for embryo or fetus? Well, the British Medical Ultrasound Society published these numbers in 2000 and reaffirmed them in 2010. So if the TI is 0.7, you can expose the fetus for about 60 minutes without risk. If the TI is 1, this goes down to 30 minutes. If the TI is 1.5, 15 minutes. TI of 2, 4 minutes. TI of 2.5, 1 minute. 1 minute of safe exposure. So what will you say? I use an FDA-approved machine. There's no problem. Well, yes, but one should know that the mode of ultrasound used is very important for the acoustic output. For instance, in B mode, the acoustic output expressed by the ISPTA, a form of intensity, is 34 milliwatt per centimeter square. That jumps to 1180 for spectral Doppler. So the output is mode dependent, Doppler being more than B mode. But the output is under examiner control, and this is very important. So whether you use an approved machine or not, you, the examiner, control the output. For instance, if you move the focus or the gate sample in Doppler, you will change the output. Now, the additional problem is that every machine behaves differently. So in one machine, you can raise the output by moving the focus up. In another machine, this will occur when you move the focus down. So you have to know your machine. Here is an example of a color box, a large color box, with a TI 0.7 and the MI 1.2. We're going to move the box up and make it smaller, and this causes the TI to jump to 1.2. So just moving the box, just changing the size of the box, changes the output. Here is an example of a Doppler of the umbilical artery where the TI is 2.4, relatively high. You can obtain a good signal with a TI of 0.4. What I did is I decreased the power. Now I purposely decreased it to a maximal way so that there's still a signal, but it is not as good as before. So if you decrease it from 2.4 to 0.8, let's say, you would still have a wonderful signal with very low power. Now, most machine, the default is the high power. We've been able to convince manufacturers that in fact they should try to start with a low power, and the examiner will increase the power only if needed. Is early pregnancy worse? Well, in the past we used a full bladder. We rarely use this today. And of course, ultrasound travels through fluid without impairment, and therefore the risk was that the fetus would in fact get a higher amount of exposure. We're closer to insonated tissues when we do transvaginal ultrasound, and there is some transducer phase heating that is possible. We've said already that the worst effect is at bone-tissue interface, but of course there's very little bone in the first trimester fetus. We're not sure about how much heat is dissipated by the early fetus and the early pregnancy. The other side of the equation, of course, is the fetus susceptibility. Now, this is a table that we've all seen in our embryology books, which shows the development of the fetus. And as Brent et al. Stated, the critical period for structural teratogen sensitivity is about the 3rd to the 8th post-fertilization week. And that's 5 to 10 weeks gestational age. Another way of looking at this is looking at critical periods of development. And if we look at the different organs, we see that the central nervous system starts at about 4 and 5 weeks and goes on to 12 and later. The heart is in this time period, the arms, the eyes, the legs, the teeth, the palate, the external genitalia, and the ears. Now, 10 to 11 weeks is the mean entry into prenatal care, but it's also the time where major morphological manifestation will occur before, and minor or functional manifestations will occur after this. And in fact, in 1999, Francis Duck, in an editorial, stated that no epidemiological or other evidence was then, and he meant in the early 90s, around 1992 when the output were changed, or is now available to support the assertion of safety at these high exposures. So there's essentially no data showing that it is safe, although naturally this is very difficult to show. So we ask the question, during the first trimester, is the fetus exposed to high levels of acoustic energy? And our conclusion was that, in fact, during the first trimester, and we were speaking about B mode, the rise in TI was minimal. Is Doppler worse? Here's an example of a Doppler of the ductus venosus in a very early fetus, and you can see that the A wave is reversed, so this happened to be a fetus with Down syndrome. But we perform now a lot of these examinations in the first trimester with Doppler. We perform Doppler of the ductus venosus, transvalvular blood flow, and particularly the tricuspid valve, and we can start now to look at cardiac anatomy and function very early in pregnancy. Well, the publishing of papers on first trimester Doppler was questioned by Stuart Campbell and Larry Platt in 2000. Another article in the same journal asked the question of whether it is ethical to perform research using Doppler ultrasound in the first trimester. A very interesting study was published a few years ago on ultrasound exposure of the fetal chick brain. Now, chicks can learn and memorize the position of certain plates where food is situated. So you can teach a chick that food, for instance, is in the blue plate and not in the red plate. When you remove the plates and you bring the plates back and the chicks back, they will go directly to the blue plate because they know that the food is there. So they learned it and they memorize it. So this group of researchers exposed the brain of chicks on day 19 of a 21-day incubation period to B mode for 5 or 10 minutes, or to pulse Doppler for 1, 2, 3, 4, and 5 minutes. They assessed then the learning and memory function that I just talked about on day 2 post-hatch. And they found that B mode exposure did not affect memory function at all. But following 4 and 5 minutes of pulse Doppler exposure, 2 hours after training, there was significant memory impairment. The chicks did not remember where the food was. In fact, in separate groups of chicks, the short, the intermediate, and long-term memory were impaired, which suggested that they could not learn where the food was. Furthermore, when they received a second training session, 5 minutes after completion of the initial testing, they were still unable to learn. So today, we do NT, nasal bone, some do maxillary angle. All these are obtained with B mode, which is low ultrasound energy. But to do an entire assessment of the fetus in the early trimester, we should use or can use tricuspid valve and ductus venosus, and this is of course done with Doppler. Can we calculate how much energy is in fact applied to the fetus? Well, the answer to that question is simple. No, we can't. But we can do a little exercise that will give us an idea of the differences in exposure. So let's assume 2 minutes each to obtain the BPD, the head circumference, the abdomen circumference, and the femur length. All these, of course, with B mode. So the total energy that we will apply to the fetus, remember B mode is 34 milliwatt per centimeter square, is about 34 times 2, 2 minutes, times 4, 4 elements, or a total of 272 milliwatt per centimeter square. If we do Doppler and we assume 5 minutes to find the ductus venosus and the tricuspid, and those of you who perform those know that it can be much more than 5 minutes. Now the total energy is going to be 1180. Remember, we said Doppler is 1180 milliwatt per centimeter square, times 5, 5 minutes, times 2, 2 elements, or 11,800 milliwatt per centimeter square. This is 42 times higher than what was used for the B mode. Another interesting study recently published showed the ultrasound effects in rat liver, where they quantified the damage to the liver after pulse Doppler, and they did find, after longer exposure, there was more tissue damage in the liver. And they established that 10 seconds was the maximum exposure time to ensure that there was no damage to the tissue in that particular model. So Doppler in the early pregnancy should be used with caution. How to keep it safe? Well, here is again that table from the British Medical Ultrasound Society, and they again look at the TI, and in fact you see at the right side that above a TI of 3 they don't recommend any use, and depending on the other TIs the times are as we showed earlier. Many societies in the world have statements regarding safety of ultrasound, in particular Doppler. The AIUM, ISWOG, BIMUS, and WFUMB. And here is just an example of the AIUM statement of 2011, stating that the use of Doppler during the first trimester is being promoted as a diagnostic aid in screening for some congenital anomalies. The procedure requires skill and subjects the fetus to extended period of relatively high ultrasound exposure levels, as we showed. Because of the increased risk, the use of spectral Doppler with high TI in the first trimester needs to be viewed with caution. And spectral Doppler should be employed only when there's a clear benefit-risk advantage, and both TI and the examination duration should be kept low. In general, keeping the TI less than 1 will reflect minimal risk. The potential impact of ultrasound has never been as high as now, with an ever-increasing number of practitioners worldwide performing Doppler examination from the first trimester onwards, as was stated by Christoph Brzezinka. Remember, the whole first trimester, and that includes week 10 to 12, is the most sensitive time in gestation. Then, of course, there's the issue of the lawyers, and the issue that not only is it important for the patient and the fetus to keep the exposure low, but it is important also from a legal standpoint. So, Perform the exam only if it's indicated. Keep the output as low as possible. Keep the exam as short as possible. Both of these, of course, need to be compatible with accurate diagnosis. And this is exactly the ELARA principle, as low as reasonable achievable. Watch the TI and MI and keep them below 1. And when you start performing ultrasound, please think about the MI and the TI. Thank you.